Hello all, let's learn about Clostridium difficile infections. Clostridium difficile is a gram-positive rod, spore-forming, strictly anaerobic bacilli and is a part of the normal intestinal microbiota in 1 to 3% of the healthy adults and 20% of infants. During long hospitalization and after surgery, the disorder caused by this Clostridium difficile bacterium is often called as Clostridium difficile acidic diarrhea or Clostridium difficile infection, which is one of the most prevalent problems in hospitals and nursing homes where patients frequently receive antibiotics. What is Clostridium difficile is a gram-positive bacilli. It lives in soil and becomes a problem when broad-spectrum antibiotics were introduced in the 1960s and 70s. How to diagnose Clostridium difficile infection? It is diagnosed by occurrence by symptoms such as more than 3 or equal to 3 unformed stools in a 24-hour period and positive stool test for Clostridium difficile toxin. The investigation done to detect the Clostridium difficile infection includes colonoscopic or histopathologic findings compatible with pseudomembranous colitis. The Clostridium difficile infection is the primary cause of antibiotic-associated diarrhea and is a significant nosocomial disease. In the past decade, variant toxin-producing strains of Clostridium difficile have emerged and have been associated with disease as well as outbreaks worldwide. Clostridium difficile infection is a natural occurring species of gram-positive bacteria of the genus Clostridium. The gram-positive bacilli they are producing toxin A and B. Toxin A is an enterotoxin, B is cytotoxin. When the toxin produces strains of Clostridium can cause Clostridium difficile infection. Non-toxic strains can colonize growing culture but they are not pathogenic. Spores are resistant to heat, acid. 1993 to 2005, there were about lakhs of hospital discharges with Clostridium difficile associated infections. Average age was about 68 years, with about two-thirds being more than 65. Nearly 60% of them were females, and admission occurred to about 60% of the CDI infections. Length of stay on an average was 13 days, and nearly 10% died during the stay. Secondary diagnosis of CDI stayed longer and more died. Around thousands of patients in 2012 with Clostridium difficile acidic disease patients received subtotal colectomy treatment for bowel perforation and poor adenosis resulting from the permanent disease. So, what is the purpose to understand the epidemiology of CDI? It's to understand the causes and risk factors for diarrhea in outpatients. The method is to look at patients with complaints of diarrhea coming to emergency departments. Conduct multiple laboratory tests on the stool samples looking for different infection causes of diarrhea. So this is a study where 1,000 patients were observed and 43 were found to be infected with Clostridium difficile. Among the 40 patients, 43 patients, 40 had either known risk factors for diarrhea causing organism in the stool. 23 patients had no. It can be of epidemic strain or wherein the strain typed BAN and NAP1 027 is the strain is highly resistant to fluoroquinolones. Benign toxin genes were present, produces large quantities of toxin NB. Patient not hospitalized for 1 year, young female, less likely to have antibiotic exposure, less morbidity and mortality. 40% requires hospitalization and recurrence is the same as. What are the risk factors for CDI? It includes antibiotic exposure, recent hospitalization, advanced age, enteral finding, enteral feeding, and immunocompromised states, and GI surgery, obesity, and gastric acid. The factors that contribute to CDI include antibiotic exposure, which causes disruption of the normal gut flora, and antibiotic-associated diarrhea. This disruption of the normal flora causes Clostridium difficile colonization, which further leads to hospitalization or environmental contact. The Clostridium difficile colonization can further lead to toxin release, which can be produced because of lack of antibodies to toxin, can cause mucosal injury and inflammation. How to reduce the risk factors? Prudent antimicrobial prescribing. Use narrow spectrum antibiotics and avoid high risk high resort antibiotics whenever possible. Reduce the use of invasive devices. Reduce the use of IV cannula. Avoid discharge delays and avoid over occupancy. Proton pump inhibitors such as omeprazole and lansoprazole can increase the risk of Clostridium difficile. They reduce the acidity in the stomach and can produce two CDI infections. All antibodies are associated with CDI, especially clindamycin, cephalosporins, fluoroquinolones. Alteration of the colonic flora is thought to favor the growth of Clostridium difficile. Our clinical presentation is mostly diarrhea 5 to 10 days after starting antibiotics and maybe up to 10 weeks after stopping. Spectrum of disease includes brief and self-limiting cholera-like symptoms like 20 times it is water stool per day. Additional symptoms like abdominal pain, fever, nausea, malaria, anorexia, hyperurbanism is common. Acute toxic megacolon can be one of the manifestations with the dilation of the colon, systemic toxicity, and signs of obstruction. And colonic perforation is another observation. List of antibiotics that is frequently associated includes cephalosporins, mostly third and fourth generation, and ampicillin, amoxicillin, clindamycin, fluoroquinolones. While vanco, tetra, amlodipine, metronidazole are rarely. Signs and symptoms to repeat again is watery diarrhea, abdominal cramps, watery diarrhea about 10 to 15 times a day, blood or pus in the stools, feverish, abdominal pain, nausea, dehydration, weight loss, and loss of appetite. Recurrent clostridium is a major problem, causing diarrhea in relapses. Incidence about 25 to 30% after successful treatment. It is result from the reinfection from the spores in the environment before the bacterial flora can reach. And what are stages for recurrent infections? It's a 14-day repeat course of vancomycin, for pulse tapered 6 first course of vanco, or probiotics as an adjunct therapy, and boost immunity with Clostridium difficile antibody, or bacteriotherapy, or stool transfer, or vaccine. The treatment includes discontinued antibiotics which is presumed to have caused precipitated Clostridia infection, suppress the growth and toxin production of C. difficile by oral metronidazole, vancomycin, or fidaxomicin. Big causes for vancomycin resistant enterococci. Relapses is common. So second course of treatment with same antibiotic is frequently successful. Replacement of the intestinal flora can be one alternative. Antimicrobial drugs should not be given. Surgical intervention may be required as for toxic megacolon and perforations. The present slide shows the agents with their adult dose and durations and comments. When there is a Clostridioides difficile colitis, discontinue the offending antibiotic, establish the disease severity, and based on the disease severity, whether it is mild or severe or complicated, the treatment includes metronidazole for mild cases. For severe cases, it is vancomycin, and for complicated, it is vancomycin with increased dosage. The pathogenesis of the model for Clostridioides difficile interdisease includes that first there is an acquisition because of the antimicrobials, and post Clostridioides difficile acquisition there is an asymptomatic C. difficile colonization. It's further because of the hospitalization transmitted infection because of the acquisition of the toxin strain of the C. difficile and failure to mount an antibody response. The repeat again is the ingestion of the spores transmitted from other patients or from the environment, which germinate into vegetative forms, altered intestinal flora because of the antibodies arouse the proliferation of C. difficile, and then further they produce toxin A and B, which leads to colonic damage or pseudomembranous colitis. So this present slide shows about the CDI severity scoring system and summary of the recommended treatments as mild, severe disease, severe complicated disease, and recurrent CDI. That's all from this presentation. Thank you.